moving to PARP inhibitors. Where do we use them? Should we move them to castrate sensitive? Is really the question. There's no FDA approval as of now, but it's coming, right?
Yeah.
So how do you guys decide?
So, I mean, as of now, if there's an approval, I certainly would be very interested in doing it in castrate sensitive. But as of now, there isn't, and I don't, feasibly, I don't think there would be a way to acquire them for most patients for practical purposes.
Yeah.
So right now, I'm limiting PARP inhibitors to the castrate-resistant setting.
But do you use them the moment they turn castrate resistant if you know that they are HRR mutated, or?
At least I don't offer them. Yeah, I have a little preference of doing PARP before chemo, but
Okay.
if a patient wants to do chemo first, that's fine too.
Okay.
It's another situation where I don't think we know the right sequencing of the therapy, but
Well, there is a study of rucaparib versus docetaxel. That's the only medication that has actually shown better efficacy in a head-to-head comparison against docetaxel. Nothing else has gone up against it that much to really compare.
Yeah.
But-
It will be a really interesting question, this castration sensitive. I'm blanking on the name of the amplitude?
Amplitude.
Yeah.
Yeah.
So because it will be, the paper's not, the full manuscript's not out yet, it's presented at ASCO this year, but we expect patients to be on ADT plus an ARPI for 3 to 4 years on average. So are they going to be on a PARP inhibitor that whole time too? And then that brings up quite, and I think I would certainly think about it. If the survival benefit is convincing, then I think that's important to patients. But it does raise financial toxicity, and then it raises the question about myelodysplastic syndrome. I don't know that we know, and I don't know the gyn-onc literature very well, but we have people on PARP inhibitors for 5 years, 6 years. What?
I don't.
So it will be really interesting, I think, to see what pans out.
That is a concern, you're right, about the MDS or marrow being impacted. And I mean, there is what came out to me from the amplitude data is how badly HRR mutation patients are doing in metastatic disease. They had such a limited survival of 24 months, 26 months, something like that.
Makes you worried about myeloma.
Right, which is sadly enough, I know, the state of affairs today now.
Which is why if you had to predict what's going to happen when there is an FDA approval, people are going to get PARP inhibition, right, in the castrate-sensitive setting.
Oh yeah, I think so.
If they have an HR mutation.
Well, but I'm not sure about how many other treatments those people got. So, is the survival because they just got the PARP inhibitor and then nothing else? Or, I mean, they got the ADT plus oral, obviously, but I just don't know what is happening with the rest of the treatments if the control arm and the other arm is getting.
Yeah, that's the question. Is that's a huge question. Yeah, it's kind of better than sequencing. That's the question that
So if they've had triplet therapy in the castrate sensitive, if you're going to do chemo, do you do Cabazi or do you do docetaxel again? Let's say it's been 2 years since they had docetaxel.
I would re-challenge with docetaxel.
Challenge. What about you, Frank?
Yeah, I more commonly do cabazitaxel, but
I do too. I tend to avoid the neuropathy and the hair loss, more from a toxicity standpoint, I feel, than anything else. But again, yeah, you're right. I mean, previously, the best second-line therapy after docetaxel used to be re-challenge with docetaxel. So.
Lung cancer paradigm of 6 months, if they recur within 6 months of getting docetaxel, I definitely wouldn't give it again.
Give it again.
I would not give it again, but yeah, if it's been a long time, I will definitely think about re-challenging them with docetaxel.
I don't want to go backwards, but back to the PARP inhibitor thing.
Okay.
We're considering everybody DNA repair proficient or deficient, but obviously that hides the complexity of what gene is actually mutated. Clearly, the data would support using them for patients with BRCA mutations, but what about other things like ATM or PALB2? Are you guys using PARP inhibitors for those patients?
I mean, I am, because now there is more and more data. The Lancet paper just came out of all comers to that enzalutamide or any of these ARPIs impart BRCA-ness. And so you can use the PARP inhibitor in combination and get a benefit. Now, there's also overall survival benefit, which is very surprising, but I think there is something to that. So absolutely, for all HRRs, at least I am considering PARP inhibitors? What do you think, Frank?
I'm not doing them very commonly.
Not for ATM and stuff.
Well, at least unless I had if I had something better, I'd give
Right.
something else. Sure. Further down the line, when they were running out of treatments, of course, that's a different ballgame.
Yeah.
But maybe I should think about it a little more. But yeah, I'm kind of I kind of look at it like the initial the profound trial, the elaborate trial. Really most of that benefit seemed to come from the BRCA2s.
Yeah,
Correct.
it is. It's
Yeah,
really
majority.
challenging. Like the ATM patients were pretty much negative on Profound, and then it's interesting the FDA approved the drug for the protocol, but the protocol wrote for mutations that they never enrolled patients on. So it's like, I don't envy like our profession. Sometimes it's really hard to know. You're like digging into the supplementary of that trial. So I definitely do it in the BRCA patients for sure. And then I do think I end up trying because, like this is not a curable disease, right? And so, I do end up trying, even in the ATM patients probably at some point.
And of course, being from University of Michigan, we have to discuss CDK12. So, that has definitely, that particular mutation, both with PARP inhibition as well as, of course, potentially immune checkpoint therapy, which has not quite well been proven in clinical trials that we conducted. But definitely for PARP inhibitor, there is a hook there that CDK12 seemed to have quite a big benefit.
Yeah.
So CDK12 mutations use PARPs.
Boy, they're not that common.
Right.
Yeah.
Exactly. True.
We have a pembrolizumab trial at MBA now, so I feel like everyone's going on that trial. So I haven't used a PARP inhibitor in CDK12 patients.
I'm not convinced that it's beneficial for CDK12 patients. I think that a lot of the data that's out there hasn't shown a convincing benefit for those patients, but hopefully some of the trials will eventually answer that.
That's fair.
Unfortunately for CDK12, there doesn't seem to be a lot of good responses with any of the agents tested thus far. So it makes it a difficult patient population to really come up with an effective treatment plan for.
Okay, and next directions. Name a pathway or a novel target or whatever that each of you, maybe we'll go around the room to see what you're most interested in.
Oh, I'm probably not the right
Who
one.
wants to start first? Should I go with Bob? And it could be a technology-based, anything, Bob.
We're not live, so I can think about a few things.
Okay, think about it.
So I suspect, and I hope, this is a hopeful answer for the future, that we will interdigitate radiation more and more with systemic therapy, and that whether that scans intermittently throughout time or biomarkers that I can identify who will progress or who will not, is that maybe a hope for the future is that radiation, hopefully radiation with lower side effects, can buy more time off of systemic therapy entirely.
That's fair.
Yeah, I certainly agree with Bob. Being a medical oncologist, we'll talk about pathways, and I'm also a science guy. The biggest thing I kind of see coming is the drugs that they're targeting either EZH-2 or polycompressor 2 complex. There's two companies working on those, and I think both of the drugs are promising. So I really want to see how those pan out.
Yeah, that looks very exciting. You're right. There's a lot of provocative, exciting, promising data with EZH-2 inhibitor, along with ADT and ARPI. Phil, you want to pick? We'll pick last.
I mean, I think, I think that one of the failures in prostate cancer has been immunotherapy thus far. And so understanding if there's a way to sensitize these tumors to immunotherapies, which have been a success in other tumor types. Certainly some of the bispecifics that are being tried against STEAP and these other things are exciting. Yeah. And then antibody drug conjugates, which have been effective in other tumors. There's some, I think you have a phase 1 trial of one of them right now. I think those are all exciting avenues for future research exploration.
Yeah, I mean, I agree. I was going to have a similar response, which is I think the new drug technologies, radioligand therapies, bispecifics around STEAP, these could be real difference makers, right? We're just at the beginning of certainly the radioligand therapy era. I think it's going to look a lot different 10 years from now. So I really have a lot of hope that our systemic therapies are going to be dramatically better over the next decade.
Yeah. I think for me, like, my area of research is like outcomes and implementation science. So I'm not as up to speed on like the early phase trials, but I think like our discussion has definitely raised the importance of getting like the right treatment to the right patient at the right time.
Absolutely.
And like, can there be people that like think one of the challenges, and I think maybe part of the treating individuals with prostate cancer that I enjoy, it is such a heterogeneous disease. Like some people are not going to die from their prostate cancer all the way to extremely, extremely aggressive prostate cancer, which is kind of different than other, solid tumors. So are there people that we like could give treatment holidays to, and could take a break off treatment? Who do we need to intensify for? So I think just even knowing how to sequence our therapies now, so there's so many unknowns, the whole PSMA PET issue that we've talked about. So I think I'd love to see work in that area. And that's a plug, I think, for some of the work that a lot of myself and our colleagues do, because there may not ever be, prospective trials looking at some of these questions. So I think that's my plug.
Yeah, no, these are wonderful things. For my purposes, I will say that the B7H3 ADC is showing a ton of promise, as Phil mentioned, in really advanced prostate cancer pretreated metastatic disease. Also, AR degraders type of things are very attractive because they are hormonally based, and you have much less toxicity in theory. But I agree with Phoebe that we do need to be very careful about balancing the risk-benefit, factoring in all the multiple comorbidities. And I will put a final comment on neuroendocrine prostate cancer, which can be de novo or it can be transdifferentiated, undifferentiated prostate cancer. And that is a very aggressive form which doesn't produce PSA and usually has visceral metastases. We at Michigan, we led a study of lenvatinib plus pembrolizumab, which is showing some promise for immunotherapy, which currently is not approved for neuroendocrine prostate cancer. And there are a number of novel targets that we are working on with translation into clinical trials. With that, thank you, everyone. And this was an amazing session. Really enjoyed the interaction. Thanks all of you to being so engaging.